So we're checking constantly whether patients are cashing in their prescriptions for metformin, because, to be honest, part of our payment is linked to that. And this patient, this lady who I'd known for a long time, I knew wasn't cashing in her prescriptions for metformin. So I knew she couldn't possibly be taking it. Nothing prepared me for what was going to happen, because the minute she came in, she was clearly an angry woman. And that surprised me greatly. And she said, well, you think you're going to tell me off? Well, I've got news for you. I'm going to tell you off. Well, when you do my blood sugar, you'll find I've got a normal blood sugar, despite the fact I'm not taking your medication.
My guest today is Dr. David Unwin, who's done something most doctors are told isn't possible. He took patients with type 2 diabetes, a condition that we're all taught is progressive and permanent, and he watched them reverse it. Not manage it, reverse it. David is a GP at Norwood Surgery in Southport in the UK. He's the clinical expert in diabetes for the Royal College of General Practitioners and an ambassador for the All-Party Parliamentary Group on Diabetes. And he was also named NHS Innovator of the Year. And his surgery now spends around £68,000 a year less on diabetes drugs than the practices around him. He's also the man behind the sugar infographics, the ones that show you a bowl of rice sitting next to the teaspoons of sugar that it contains or it turns into in the body. So if you've ever had one of those land in your feed, or you've seen them on my videos, and they change the way you look at your dinner, this was down to David. David, welcome. Thank you for making the time.
Well, thank you for the very kind introduction.
So where it all started, take me back to 2012 and your patient who walked in having reversed her type 2 diabetes on her own. What did that moment actually feel like? Because I seem to remember that you were quite incredulous that this was even a thing that was possible.
I think we ought to just wind a bit further than 2012, and that is to explain the problem that the practice had. So the problem we had is, we're a practice north of Liverpool. We've got 10,000 patients, and we'd suffered a 10-fold increase in the number of people with type 2 diabetes since 1986. So there were 10 times more people. And that brought with it a lot of workload problems, obviously, because we had the same number of doctors and nurses. And it wasn't just type 2 diabetes, it was also obesity, high blood pressure, many conditions impacting really seriously on our workload. And as part of that, I was becoming exhausted and mildly depressed. And so really thinking about leaving general practice, as most of my friends were when I was 55 at the time. And then, one patient changes my life and the many other people's lives as well, really.
Are you still in touch with her today?
And sadly, I'm not, because she left the list and moved way away a few years ago. So I lost her at that.
What if she has any idea what she started?
I would imagine so, because the story is kind of famous. Or has become notorious or famous. So, yes, anyway, so at that time and still now, to an extent, we're paid to check that our patients are taking the drugs that are appropriate for type 2 diabetes, and the commonest drug is metformin. So we're checking constantly whether patients are cashing in their prescriptions for metformin, because, to be honest, part of our payment is linked to that. And this patient, this lady who I'd known for a long time, I knew wasn't cashing in her prescriptions for metformin. So I knew she couldn't possibly be taking it. And there's a kind of standard response to that is you write to the patient to say, dear Mrs. So-and-so, I'm sorry to notice you're not taking a medication. Maybe there's some reason. Please would you make an appointment for us to discuss this? Nothing prepared me for what was going to happen, because the minute she came in, she was clearly an angry woman. And that surprised me greatly. And she said, well, you think you're going to tell me off? Well, I've got news for you. I'm going to tell you off. And her point was, she said, well, when you do my blood sugar, you'll find I've got a normal blood sugar, despite the fact I'm not taking your medication. And I've lost 3 stone in weight. And she looked fabulous. She really did. And then she said, so the question is, why did you never once tell me in those 10 years that maybe if I didn't eat bread and rice and potatoes, I wouldn't need to take metformin? And, I'm actually wondering whether you're qualified, because it's schoolboy, and she was right, of course, it's schoolboy biology that starch carbs digest down into glucose. And I was really scared because she, number one, she looked great. And two, she looked angry. And she was correct. She was absolutely correct. And I was so confused. I was caught on the back foot because I thought, well, actually, that's a fair point. I did, we had learnt when we were about 16 that bread turned into sugar.
Yeah.
And I thought, crikey, well, I wonder why I haven't mentioned that. So the only way...
Practice for decades at that point. So,
yes.
So when she left your office, did you just start thinking, I need to know more? Where do I start?
Oh, yeah. Well, before she left the office, because all the doctors know that if you have a complaint, you've got to start listening. If you're in denial, it makes people cross, understandably. Yeah. So the only answer to a complaint, a genuine complaint, is shut up and listen. And she had stuff that I needed to know, and I had stuff I needed to learn. And of course, it ended happily in a way, because that one consultation is one of the main reasons that I'm still in practice age 67 and one of the oldest working GPs in quite maybe 100 miles radius now.
Yeah.
So she left me with resources because she told me where she'd learned this. And so I had homework, and we agreed to meet again when she'd had the blood test, which of course did confirm that her blood sugar was normal. And then I was able to ask her more, and we took it ahead and then started a group. Jen and I started a group of 18 people, and we learnt with the patients about
Jen being your wife.
Yeah.
Yeah. Yeah. And this was pre continuous glucose monitors. These hadn't gone to the market yet, or had they?
Not at all. No. Well, I think that's a good question, actually. They may have been there for type 1, but I wasn't at all conscious of continuous glucose monitors, and it's not what we use. So that we started in January 2013 with group consultations. Yeah. We use a lot of CGMs now, but no, we didn't. We relied on blood tests at the time, and the results were frankly astonishing because we replicated what she did with practically every single one of the group. And including myself, we all lost about 10% of our body weight, felt loads better, blood pressure improved, and every single blood test we did improved. Wow. And then we published it. It was the first, I think we've done 30 peer-reviewed papers now. And that was the first one on just those first 18.
Yeah. And what did it cost you professionally to start saying this out loud? Because initially it must have been, well, let's test it with this one group and see how it goes. But once you started to see results, I'm sure you wanted to shout it from the rooftops.
It was problematic at many levels. So it was problematic within the partnership, because even though I was senior partner, the other partners didn't think this was a very good use of my time.
Right.
And also it worried them because they really weren't sure what would happen to the cholesterol levels and all the rest of it. And they couldn't understand why I seemed to be experimenting on my own patients. And so they thought I shouldn't. I felt very strongly I must, because the results were so good. So we argued and argued about it in the early days. So there was arguing and problems there. And that's why we ended up doing the group consultations. And Jen and I worked for free to do that. So we said, okay, well, can I do it if I don't get paid?
Yeah.
And that was Jen's idea. And that they grudgingly said yes. And I said, well, we could just do it for 6 months and let's see how it goes. And I'll admit it if the results are poor. So there was a problem there. Then when we published, then there were bigger problems in that I started getting hate mail from professionals who felt the approach was cavalier. They thought there'd be vitamin deficiencies. And then when I wrote back and said exactly which vitamins, then they're just really cross. There were one or two very challenging meetings where I would present the data. And I remember one time a consultant endocrinologist really shouting me down and said what I was doing was irresponsible and there would be deaths. And he was really hopping mad with me. And a lot of dietitians didn't like the approach. And I remember I'd be chatting to a group of dietitians, and then I'd introduce myself, and then sometimes they would just turn their back on me. and refused to even speak.
Oh my gosh.
That has changed a lot. I have to, now, this is years ago.
I mean, they don't know that it takes something like 20 years for an idea to become mainstream. And you were at the beginning of that, and you witnessed that.
I don't think that's I don't think that's quite fair in a way, because in the early 1980s at medical school, I was actually taught carbohydrate counting.
Okay,
it was there, and low carbohydrate
diet that had been around since the 70s. The Atkins diet.
That's right. So it's not my idea. First time, the low carb diet was actually published the first time in 1797 by Rollo in Edinburgh. So all I've done is helped resurrect basically the approach where you don't eat food that puts up your blood sugar, which is hardly like a revolutionary, amazing thing. And that's what really shocked me, because I thought it's such a simple thing. I'm just suggesting that people don't eat food that puts up their blood sugar. Why are other people so angry about this? What is the source of their anger? Because I was starting to not use drugs, which to me would seem like a good thing. And I just couldn't understand why healthcare professionals were so cross.
And I suppose it also goes against what everybody thought he knew about the food pyramid and filling our plate with vegetables and starches, and protein being the smallest part, and fat or protein being the minor part, compared with the bulk of what we should be eating. And
my own advice for years was healthy whole grains, and I, possibly with a banana, and I personally was adding sultanas. So I was adding sultanas to my all bran and that kind of thing. So it was a 180-degree turnaround from what I'd been advising patients. And it was difficult for me, and I felt a bit vulnerable when so many colleagues weren't happy. But the results, the magnitude of the improvements were so great. And in so many patients, I felt I had a moral imperative to, as you say, shout it from the rooftops.
Yeah, and I think I've heard you say that you would offer your patients a diet sheet. They could either take the diet sheet, or you could write the prescription for metformin, and they all chose the diet sheet.
That's true, yeah. So I just think it's good practice to say to patients, you could do this or that at this point.
Yeah.
Which would you prefer? Because then you're working together in a collaborative manner for a shared goal, rather than me telling them what we will do. What surprised me was, actually, you're right. Not a single patient has said, give me the metformin, which is great. And it kind of affirms my belief in the intelligence of people.
Yes. So results have been 51% drug-free remission overall, and 77% for people who start within a year of their diagnosis. So when you first saw those numbers coming out of your practice, did you believe them? Did you think, that's better than I expected?
It made me anxious. It made me stressed, because I was used to papers that show a sort of 10% improvement, that kind of thing. That's the sort of thing you tend to get with drugs. The results seemed far too good. And I thought I must have missed something. They looked fraudulent to me.
Yes.
And so I wrote to 20 professors who I knew were interested in metabolic health or diabetes. And I was so lucky, because one of them, which was Professor Roy Taylor from Newcastle University, he was the only one that answered my email. And he said, this is important. You absolutely must publish it. I will help you with the statistics. And he got me published. And I'm always grateful to Roy Taylor, because he emboldened me and recognized that it was valid and maybe even important.
Yeah. But there was something in the figures about people who were diagnosed more than 15 years ago. That they didn't have as much success as the people recently diagnosed. What's different about that group? And what do you say to someone who's sitting in front of you, diagnosed 15, maybe obviously been taking metformin for 15 years?
Yeah, so this is in our BMJ paper published 2023, which had Roy Taylor as the senior author. And what we were looking at, what predicted success defined as drug-free type 2 diabetes remission. And there were two important things came out of that. One was the longer you've had type 2 diabetes and the worse your control, the less likely you are to get remission. So that at 15 years, you're down to about 20% chance. But those aren't bad odds. The most important thing, though, was that even though people didn't get remission, which is a normal blood sugar without drugs, they had really significant improvements in blood sugar. So the fact they didn't get remission, to them, wasn't always the point. The point was they were much healthier. Their blood pressure was better. We saw improvements.
Maybe they never expected to achieve remission.
No, exactly. So
anything was going to be an improvement.
Yeah. And we documented improvements in all cardiovascular risk factors for them. So they'd improved their diabetes. Many of them had come off drugs, but hadn't necessarily got their blood sugar into the normal range. And I think it points to it's not your chronological age that matters. So the oldest person with remission was 92 years old. So it's not that older people won't do it. The factor is it's your metabolic age. How long have you had the diabetes? And the best figure was we get 93% normal blood sugars for people with pre-diabetes because they're metabolically younger. So we nearly get all of those sorted.
Okay. And maybe it's a case of how long the body's been under that strain and been dealing with it. And maybe it gets to a point where there's damage done and it's not fully reversible. You can improve it, but you can't take it away completely.
Absolutely.
Maybe there's just so many other things impacting their health as a result of the 15 years of being a type 2 diabetic that's meant it's less possible for people, but still a possible improvement.
Yeah, the model I have now is really that insulin resistance, which is upstream of type 2 diabetes and many other conditions, is sort of aging your metabolism. Yes. I have type 2 diabetes myself, and, I ate my way into that situation without realizing.
As so many people do, and so many of us are only just becoming aware of how close, if we're not in that situation already, how close we were to being a type 2 diabetic.
Yeah.
And that goes for people who are overweight and people who are normal weight too. It can strike anybody, and even children, as we've seen. They've even changed the name, haven't they? They don't call it late onset anymore because it doesn't onset at such a late time as it used to, unfortunately.
Yeah, you make a good point. So when I was at university in the 1970s and early 80s, type 2 diabetes at that time was called late onset or maturity onset diabetes because it was only older people. Yes. I never ever saw a single case in somebody under 55 or 60. And now routinely in clinics, I'm seeing it in 25-year-olds, and I have seen it in a 12-year-old.
Yeah.
So this is partly why I make such a fuss, because something very serious is happening to society and it's damaging our young people. And I think we're asleep at the wheel.
Absolutely. Really? Yeah. You described that first year after diagnosis as a window of opportunity. Most people don't even know that window exists. Whose job is it to tell them?
Well, I'd say, it's healthcare professionals. It's certainly my job to give them the chance. And that's the worry that I think doctors and nurses and health coaches, and if you know something, you should. So it's not always about telling people what to do, but it's about sharing information. I think people are entitled to know that remission is something that's easier now than in 5 years' time, and basically get cracking. And I think surely it's my responsibility to tell people. And the proof is the number that they've all said, yes, please.
Yes.
And that isn't generally happening.
But I also feel that I feel we shouldn't be relying on a health professional as much as educating ourselves about our own health and being responsible, not just expecting someone to fix it for us, but actually taking responsibility, because you live in your body. You know yourself better than anybody else.
Yeah. That's a very good point. It's a bit like when you deal with teenagers where you're encouraging them to take responsibility for their lives. But I think doctors have some responsibility for this, because we've got into the habit of medicalizing people. So they become slightly passive recipients of our expertise, when the reality is, the painful reality is that diabetes can do a lot of damage, that without partnership with doctor and patient, you can't get the best results. So to remain passive is dangerous.
Yes. And we've also got to a point where people don't trust what the doctors are saying like they used to. People don't trust authority figures as they used to. So even with the best will in the world, you can't help people if they don't come to the doctor, and because they don't trust doctors anymore, because doctors just prescribe drugs. There's that whole body of thinking, isn't there? And that's where sharing information can sometimes be negative, because people are sharing all sorts of ideas that spread and spread and spread because of the internet. And not all of them are necessarily the best things to be sharing, but we're all sharing them regardless.
Well, yes, and in amongst that is a mixture. Some of it might be correct or might be incorrect. So that what we've ended up with is a slightly confusing soup where people perhaps feel a bit less safe. And that's a great shame. But I would really encourage people to learn as much as you can about the effect lifestyle and diet has upon you, because it's powerful. And at the very least, you could experiment a little and try this and then try that, but measure stuff. So measure your waist circumference or your blood pressure or your weight, or you might get a CGM as you have and as I have, and then you can find out for yourself, well, how do carbohydrates affect my blood sugar? And that could help you learn a great deal.
Well, when I did a episode about CGMs, I've been doing a month of wearing a CGM and showing people what effect it has on me and the food I'm eating and the food choices. And people have been sending me, try it with this, try it with that. What about a Diet Coke? I haven't gone down that road yet. But, when people have come back and said things like, yeah, but you only wear it for 2 weeks and it costs 40 quid, or it's a lot of money. And I don't feel that is a lot of money for the information it feeds back to you for 2 weeks of your life that you had no clue about before. And now you've seen what 2 weeks of your normal eating does to your blood sugar. That's worth £40.
I mean, the most valuable thing anybody has is their health. And as you get older, that becomes plainer and plainer. Yeah. And then you have to think, well, so it was 40 or 50 quid. But hey, what about birthday presents and Christmas presents and things like that? Maybe your relatives might buy that. Wouldn't that be a more loving gift than more knick-knackery when you already have vases and pictures and knick-knackery? So, it's about a system of priorities and what you value. Yeah. And it's been surprising with the new GLP-1 drugs. People will pay £200 or £300 per month for injections, which have to be carried on indefinitely. And yet a CGM might mean you never need those injections. So it can actually be an investment to learn.
Exactly. And as soon as you stop those expensive GLP-1 injections, if you haven't changed the underlying behavior, you're going to go back to square one.
Of course, yes. They're another window of opportunity if you do use them. But the only thing, you must learn to eat differently. Yeah. Otherwise, the same result will come.
And humans are lazy. They just want the easy line. They just want get me from A to B as fast as possible with the least amount of effort from me. Yeah. And we're all guilty of that. We all choose the easy path rather than perhaps the road less traveled. But so 93% of your pre-diabetic patients went back to normal. Yes. And pre-diabetes is the point where everything's still winnable. You've still got a good chance of reversing everything.
Yes.
So why is it so often watch and wait? Why are we not just going straight in, going for the jugular on this?
Yeah, that's a very important question. I was guilty of this. My paradigm was one that was centered around using drugs. Mm-hmm. I was kind of, for 25 years, sort of waiting till I used the Metformin. And also, I gave people advice about losing weight, but very few of them seemed to do that. So I became dispirited. And yet, of course, the problem was my advice rather than the people.
Yeah.
And so, and then the other thing is the health service is absolutely struggling with the workload of the 10-fold increase in type 2 diabetes and obesity and blood pressure and central obesity and increasingly cancer.
Yeah.
So that, with 10-minute appointments in primary care, what you're actually doing most of the time is you're scanning for really dangerous stuff. Because if you miss a breast lump or you miss something dangerous, so that you've two things. One is a tendency to use drugs, but the other is because you're so worried about somebody dying because of an error that you made, you're looking for the dangerous stuff. So prediabetes doesn't appear to be that dangerous, and yet downstream of prediabetes is significant mortality and morbidity. It's just that it takes a bit longer.
And do you feel it's the beginning, as I do, it's the beginning of everything? Because if your diet is filled with unnecessary sugars, other things spread out from that. So all those other problems you just mentioned can be as a result of that diet that has too much sugar in it, too many spikes throughout the day, causing these high blood sugar readings until your body can't cope anymore.
Yeah. I think it's time we mentioned insulin, really, and hyperinsulinemia and insulin resistance.
Mm-hmm.
So a high blood sugar is actually damages your arteries remarkably fast, within hours. And so nature designs you to control your blood sugar within very small parameters. So a high blood sugar is very dangerous, and a low blood sugar, you're unconscious. So it's controlled, and it's controlled by insulin. Insulin takes glucose in the blood and gets rid of it by packing it inside cells where it becomes fat, or energy for muscular activity.
Yeah.
The problem is that most of us now eat more carbohydrate than we need to run around. So the excess carbohydrate becomes fat, particularly in your liver. So that a third of everybody now has fatty liver. A third of everybody in the world has fatty liver, many children. And fatty liver interferes with the good work of insulin. So you are becoming insulin resistant. And this state of insulin resistance is about 10 years before you develop type 2 diabetes. But other things are beginning to happen and go wrong. Linked with a fatty liver, you're also likely to develop high blood pressure. You're likely to have a big tummy. And that's all associated with 8 forms of cancer. So this is actually huge. And I'm beginning to think, I think it's about 80% of all of the work in primary care. When you think of the effects of insulin resistance on mental health and dementia, anxiety, maybe even things like bipolar disorder, and then skin condition and polycystic ovarian disease and cardiovascular disease. Well, isn't it most of what I do in general practice? So I now estimate that insulin resistance is responsible for about 80% of the workload in primary care, and type 2 diabetes only a small part of what I'm doing day to day.
And I think it's important for people to understand that as blood sugar rises, blood sugar is followed by the insulin a little bit later.
Yes.
They're not one and the same thing. The insulin is the hormone, the fat storage hormone that comes out to deal with the blood sugar as it rises or after it's risen. And yes, people don't understand the basics of it. They don't understand the mechanism. And the body tries and tries and tries until it gets to a point where it can't cope anymore. Yes. And I've explained to people, your blood in a normal situation has 1 teaspoon. It can cope with 1 teaspoon of sugar in your entire bloodstream.
Excellent
and as you talk about the tight parameters, you have to stay within those tight numbers. And more than 1 teaspoon is constantly pushing it outside of that. So that's how crucial this is. It's not just, I shouldn't really eat as much sugar. No, you shouldn't. This is so serious because this is all the other things it leads to. And when you say things like the signs in advance, high blood pressure, so prevalent, high blood pressure. And what do? We take drugs to lower it. What's caused the high blood pressure? Why are we not asking more of those sort of questions? And outward signs like skin tags. Skin tags aren't they an outward sign that you didn't have? You weren't born with them. They've and sort of that dark velvety patches of skin that you see around people's necks. There's other ones
as well. And it's odd how we all lack curiosity to, there's an epidemic going on, and it's very odd that people aren't curious as to, well, why is this happening? Why are people so much fatter?
Yeah, but I don't think they believe they can change it. I think they just think this is it.
That's it.
Oh, It's normal.
I think they've become confused. I think we've had so much confusing eggs are bad, eggs are good, this food's bad. So I think some people just think, well, I don't think they know what they're doing, so why don't I just eat what I fancy? And then the other thing is I've become allergic to the term moderation, because everybody, what on earth does that mean? Moderation, also the other word is balanced. What is balance scientifically? What is moderation? What's the weight? What's a moderate amount? And these terms, and then the idea of treats, which now is something you seem to do 3 times a day instead of once a week. All of this leads to the overconsumption of junk food.
And all of it's normal.
People would watch me eat, and I don't have bread and I don't have potato, but I have green veg and I have berries, and I eat the meat and the fish and eggs and cheese. I eat all the stuff, the nutrient-dense stuff, and yet people think I'm very odd. Well, I am odd because I'm not taking medication. Well, that does perhaps make me odd, is a way to say it.
That gets really questioned if you go to talk to any health professional and they say, well, nothing, you don't take anything. My mum is 79 and she doesn't take any medication, and they always question, what? And then they start checking things.
Well, of course, now most people over 70, I think there's, on average, they're on 5 medications. People over 70, and the cost of it is huge.
So where does stress sit in this picture? So let me give you an example. With the continuous glucose monitor, I can drink black coffee on an empty stomach, and it will push my glucose up without eating anything. And my understanding is that's because it raises cortisol. It causes a stress response in my body. If we think about how stressed we are generally about with so many things, and the body perceives all stress as the same, it's all like running away from a tiger. How do you deal with that with patients when you know that their life is a car crash and they've got so much on the plate already?
Well, so for me, again, I've got 10-minute appointments. I'm looking for the low-hanging fruit. I'm trying to be effective and help them in very little time. So that's why I go for diet, because it's much easier to help people with diet than it is with stress. However, once people have had the success with diet, they then can notice, I think, let's take me. So when I was 55, I was very stressed. And my diet was terrible, and I never really had a good day. I was tired every day and needed a little sleep in the middle of the day. So I just wasn't reading the signals from my body because I was chronically unwell, really. However, when I'd once sorted out my diet, I then could notice the effect that stress had upon me, or sleep, or various other things. And then I was able to fine-tune my lifestyle, which includes exercise as well, to get things even better. But telling people to relax is very unhelpful, because that just then, we've all laid awake at 4 a.m. thinking, I'm going to feel terrible today because I'm not sleeping. I need to get to sleep. It doesn't. Dealing with stress is far more complicated. There are things you can do. I personally find yoga very helpful. I find running very good. I find time with nature outside. But suggesting these things to people who are unwell in modern life in a 10-minute appointment makes it sound very woo-woo, really.
Yeah, like a bit of a crank.
Once you sorted the diet, and then you start really thinking about your health, you might start thinking about going to bed routinely a bit earlier, reading first, the lights, and all of that does make a difference. Actually, magnesium makes a difference too. I don't know whether you supplement with magnesium.
Absolutely,
but that can make a difference. So yes, stress is really important, and I've often seen with a CGM that while I'm doing public speaking, my blood sugar may double. And I haven't eaten, it may double, and I haven't eaten a thing. So all of that is important, as I say, and sleep and exercise, and possibly light in the morning makes it. There's all sorts of things that you can go to the next level once you're interested, but not much of that will do you good if you haven't sorted out the junk food first.
No. And maybe people, once they see one improvement, maybe then they'd be slightly more open-minded to the next one and the next one, because it snowballs, doesn't it? It goes as fast as it can spiral down in the wrong direction. You can come back out of that, and you can change things around really quickly. And that's the thing that fills me with joy when I'm coaching people, is that they come back 2 weeks later, we have a second meeting, and they can't believe that they're already feeling better, that everything's feeling better. Sometimes they're even feeling better after the very first conversation, but because they've got some hope that they can change. I've given them hope that they can change this, and you don't have to settle for this. Yes, it's normal, but you don't have to be normal. You can be exceptional just with a few changes.
Before you move on, I just support this idea of hope. It's very powerful.
Yeah.
And it's the basis of my wife's work, her life's work. So she's a consultant psychologist, and her research is on wonderful Fork in the Road. Yes, get it on Amazon, people. It's the book on food addiction. But yes, hope is very powerful in changing outcomes in chronic disease. And some of what I do is give people with diabetes and poor metabolic health hope that actually their future depends upon them. Each of us has a range of futures, and there is an extent to which we pick our own future in the daily choices that we make.
Yes. Oh my gosh, yes. It's not just down to my genetics or the inevitable passage of aging. All these that's one of the phrases that I can't stand. This assumption that we've just been led to believe all of our lives that we have to be looked after, take medication, go to the doctor, have vaccinations, all the things that will keep us safe, instead of just eating the right food and choosing our own path, as it were.
Yeah, absolutely.
So would you say low carb? Because this is another thing people will say, oh, is it a ketogenic diet? It all sounds so horrible and restrictive. But would you say low carb is a therapeutic phase or a life sentence? Because somebody who says, oh yes, but I love my bread, I could never give it up. It sounds like a life sentence. It sounds like this is the rest of my life's going to be terrible because I can't eat this, that, and the other.
I think the first thing is enjoying food is a really important part of being human. And so the first thing is, I've been low carb now since the end of 2012, 2013. So I haven't eaten bread in all that time, but I've enjoyed
at all. Oh my
gosh, because it just makes me ill. So I don't enjoy it enough to put up with how I feel. So the loads of foods you can enjoy, that's the first thing. Then the other thing is, well, it depends. The proper framing might be lower carb. So I'm trying to encourage people that it is, as it were, a spectrum. So I have patients who are on huge amounts of carbohydrate initially, and then they achieve drug-free diabetes remission, still on maybe 180 or 200 grams of carbs a day, because previously they were on so much. So I suppose I encourage people to move down the carb spectrum and see how they do. The big thing is doing something and maintaining it are two very different things. So many people, in inverted commas, are good. But the challenge in the world is, can you maintain it? So once you've got drug-free remission and you think, I feel fabulous.
Yeah.
And then sooner or later you go on an all-inclusive holiday, or it's Christmas or somebody's birthday, and then you start to slip and then you don't feel as good. And so this is the thing, because I believe many ultra-processed foods to be addictive. And so can you truly eat one biscuit or a tiny piece of cake? I just find that torture, and it irritates me. And I've learned to do without it rather than be irritated, and focus on foods I do enjoy.
Yes. And also your taste buds change when you cut out sugars.
Yeah. Excellent point. So if you cheat, one of the great benefits of low carb is the lack of appetite. So patients nearly all tell me they're not hungry. And that's because
noise switches off.
Yes. So actually low carb stimulates the natural production of GLP-1 hormone. That's how it works. So you're much less hungry. However, if you have cheat days, then you end up hungry again. And then that drives you to eat more. And the result is poor metabolic health.
And then you think it's not working. And in fact, you're just not doing it the way you set out doing it.
Correct. Yes. So people who go low carb need guidance, and they need help long term, because the world wants you to go back to eating junk.
Yes.
And how low to go is the question. Well, some people do need to go so low that it's keto in order to achieve good health. Other people do not. Jen is lower carb than I am because of her food addiction.
Yeah.
So each of us the thing is experiment, but if you're failing, admit it. And if eating carbs, if it's addictive and you're gradually going back to your old ways, you will end up ill again.
And some people don't appreciate how addicted they were until they try and cut them out.
That's really amusing. They think that I say, well, great, do it. Show me you can do it. And then some of them find cravings are a real problem. Not initially always, but maybe after a few weeks. And they have to work through the cravings. So that's, as I say, it's really the idea of maintenance. But you can't do that until you realize how well you feel and how good. And it's also down to your priorities. Do you actually love bread more than your kidneys? You know, or your vision? Yeah. Because I see people in every clinic who end up very ill, and eventually, of course, diabetes shortens your life by about 10 to 15 years. So we trivialize. We trivialize the effect of diet.
Yeah, I always feel that it's so. What if you live to your 80, but the last 30 years you felt terrible and everything hurts, and you're so bad tempered and you have no quality of life because life's just awful because your diet is so awful, and you've just got worse and worse and worse. You've assumed that's what happens because I'm old, and it doesn't have to be like that. So. Some people go low carb and then they stall. As we talked about, sustaining it is sometimes the hardest thing rather than just getting started. Or they feel worse. They might be sleeping badly, or their hair starts falling out, or they're cold, and they're blaming it all on the fact that they've gone low carb. What would you say is happening there? And how would you advise somebody that comes in for that 10-minute appointment and gives you these symptoms?
I think I'm just trying to think, what are the commonest things that patients tell me? I think one is hunger. So if you're hungry on low carb, you're probably not having enough protein.
Exactly.
Very often, particularly older people, don't realize they need more protein when they're 70 than they did when they're 60, because preserving muscle mass is absolutely key to longevity and muscle strength. So that's one of the commonest things, is actually people, they've cut back on everything. And they're actually not eating enough.
Not really hungry because and then they get to the evening and then they are hungry, but
and then they're snacking.
They don't sleep properly.
They're snacking. The other thing is some people are eating too often. So a little and often is a problem. You're better off with 2 big meals a day than you are 5.
What we were told 10 years ago. In fact, recently, a girl I know here, a Spanish girl in Andorra, said, "Oh yes, I went to the nutritionist and she told me I needed to eat 5 times a day and have a little snack so that my blood sugar doesn't drop too low." And I just thought, oh my gosh, this is so upside down. But what do I say to her? She's been to her nutritionist who's told her this information. You know, we started snacking around the time my daughter was born. She's 34, my eldest daughter. And, you know, I remember going swimming with my sister-in-law and saying, we better take a snack for the children for afterwards. And she said, what for? That'd be all right. We'll have tea when we get home. But it was this idea we have to keep snacking all the time, and blood sugar never goes down, and it's just constantly elevated.
I think my answer to that is, again, so you're in a different position to me. So as a doctor, I can direct more.
Yeah.
You're in really, you can ask questions, which is, well, how's that going? And it's going with hunger and weight gain. Perhaps you could experiment. Have you ever tried having bigger meals, but less often, and found out how that is for you? And then, of course, what happens is people are saying to me, do I really have to eat breakfast because I'm not hungry for my breakfast? And I'm saying, you absolutely don't. And I don't usually have breakfast. I haven't for years. I don't need it anymore because I'm not hungry.
Yeah. Yeah. So, if we can just briefly touch on cholesterol, because it comes up all the time and everybody's told it's the thing that doctors shout at patients who don't want to take statins because they're going to die from high cholesterol. People tell me this often. LDL, the cholesterol that's perceived as the harmful cholesterol, rises for some people when they eat a low carb diet. What do you tell them, and what do you tell their GPs?
So the first thing is, so what you're touching on there is probably the lean mass hyperresponders. So The first thing to say is that in the 13 years, I've only found one of those. Only one. It's incredibly rare. And so there's far too much attention given to something that is very, very rare. So we published in BMJ Nutrition, on average, what happened to LDL and cholesterol and triglyceride and all of them. We saw significant average improvements, all of them.
Yeah.
The cholesterol improved because a lean mass hyperresponder is somebody who's lean. And very few of my patients are actually lean. On average, they weigh nearly 100 kilos.
Okay.
So it's a very rare problem. So Jen, my wife, is a lean mass hyperresponder. And in her case, she had to have her coronary arteries scanned for the calcium in the coronary arteries. And she has the coronary arteries of a newborn baby. She has a 0. She has a better calcium score than me. So her cholesterol is 3 times mine.
I saw her in the film.
Yes. And her coronary arteries are normal. So lean mass hyperresponders are very much a specialist area. And I don't meet many of them in general practice. I've only met one.
Yes.
So I'm not an expert on lean mass hyperresponders because they're vanishingly rare in the north of England in primary care.
Yeah. And continuous glucose monitors for people without diabetes, would you say that's a gimmick or the most powerful teaching tool that we have? I mean, I know you've argued that it's prescribable.
Yeah. I think you learn a lot very, very quickly. I think pre-diabetes, goodness me, you'll learn fast.
Yeah.
I think it's just a reminder of what will spike your blood sugar. And the question is, how much did you enjoy that food? Is that the thing to be doing all day long? So I actually think CGMs could be very helpful in insulin resistance because more and more of society is or will become insulin resistant. So I think we've got in the States now, something like only 10% of Americans are metabolically healthy. So they're really rare. And some 10%, there's a study, and it's going like this here. And particularly if you live in the north of England, or just wander around any supermarket, you will see people with younger people who obviously have poor metabolic health. So I think CGMs, I haven't seen many cases where people have been harmed. On the whole, they've learned stuff.
Yeah. Yeah.
So I'm not saying they could never harm anybody, but on the whole, it's a bit like, well, is it wrong to measure your blood pressure? Is that a wrong thing on the whole? Or is it wrong to weigh yourself because you could become neurotic about weight and weigh yourself every day? But on the whole, isn't this a sort of ethical thing about information? And it's what you do with that information that's important. And I think it's useful, very useful.
Yeah. Yeah. And the difference between a continuous monitor and checking with a fingerprint prick blood test is that's just a moment in time, whereas this is 2 weeks constant. When you're asleep all the time, you can just constantly see what's happening rather than, because you can test one finger and a different finger and you'll get a different answer, which I've tested. And it's just like, oh, wow, it's lower over here than it is on this finger here. So £68,000 a year saved on drugs in your practice, a single surgery, published, replicated elsewhere. Why isn't every practice in the country copying you?
So the problem is that we don't get to keep that money. So although we've now saved, or I think we've been adding it up and we've saved, I think it's about £350,000 on the diabetes drug budget alone since 2018. But that money goes back to the Treasury and doesn't help fund the low carb approach in our practice.
Yeah,
so that currently, if you're doing a low carb approach, you're funding it from within the practice because you're trying to do a good thing. The irony is at
the beginning as well to get
kind
it
of working for free. And so the irony is what are the levers for change? And one of the levers for change. So if I've got 158 people with drug-free diabetes remission, I'm not rewarded in any way for doing that. So the question is, I suppose I am rewarded because I love the work, but I have colleagues who say I'm a mug because I'm doing extra work when I don't need to.
So you're the Royal College of General Practitioners clinical expert in diabetes, and you're an ambassador as well for the all-party parliamentary group on diabetes. What can you shift from the inside, and what's beyond your control? Is there anything that you feel you can do? You're lobbying the government, I understand, too.
Yeah, I am. And it's problematic because, of course, the junk food lobby are very powerful. And they're creating confusion and so on. So the Royal College of General Practitioners has published an e-learning module, which I wrote along with 7 other GPs. And that's one of the most popular e-learning modules that the college has ever produced. And it's free to every single GP in the land. So that's progress. That's good. I'm trying, a lot of what we are doing is a grassroots revolution through social media. And I'm using Twitter on the whole. I've got 120,000 followers on Twitter, and I'm trying to put out information for people via Twitter.
Yes.
To help with that. Government is a problem because they have many priorities, and sometimes you wonder if health is one of them. They did do the sugar tax, and that was helpful. I would really like to see us tax ultra-processed food, and that we would spend that money on subsidizing locally produced whole foods.
Yes.
Maybe in farmers markets or whatever, to make it easier for people on a budget to buy whole foods. Although green veg is not expensive. But I think the other thing I would ask government to do is stop giving planning permission for fast food outlets, because we know that every time they open up, people locally get fatter. So why are we...
You think we've got enough of them?
Yeah. So why aren't if obesity is a national crisis, why are we seeing so little action to protect particularly our young people?
Yeah.
I mean, one of the answers, what we're told is it's to do with freedom. But there's also if whole foods are expensive, well, then you don't have the freedom to buy them if you're very poor. And maybe that forces you to eat more junk.
Yeah. And the other thing I think people realize, because yes, it's more expensive to buy a piece of steak or a pound of beef mince than it is to buy a pizza. But when you stop eating the pizzas and the junk food, and you're satisfied with less food, you don't need to eat so often. You don't eat all the snacks you used to buy every time you bought a coffee, or you do actually overall eat less because you're satiated when you eat proper food. So
it was interesting. We asked our patients on benefits how they felt about the diet, and they said the important thing is to be honest about the amount of crap that you bought previously. And if you include in your budget the fizzy drinks and the crisps and the chocolate bars, when you go low carb, you end up spending about the same. And that's what they told me. It's about the same because we eat less, but it's higher quality, and it levels out at approximately the same in your budget. But you must be honest about what you spent before, because maybe people aren't.
Yeah. And what would you say to a viewer, and hopefully this isn't happening anymore, I don't know, maybe whose GP won't engage, whose doctor won't engage with them, or tells them that this way of eating is dangerous? Do you think there are still doctors out there saying that?
I think there could be. I mean, it's about, there's a way to do it, and it's about courtesy. And I think if you say to a doctor, I'm really interested to see what I can do to improve my own health, I'm going to try to eat better. Would it be possible for me to have a blood test so I've got my baseline, and then could I have another blood test in maybe a few months to see how I'm doing, and then you and I will know how I'm doing? And put like that, that's a very if I had a patient who says, I'm interested in improving my health, would you support me? It would be I hope it would be a very rare GP who wouldn't be pleased to hear that.
Yeah. Last one, a 58-year-old woman has just been told she's pre-diabetic, sent home with a leaflet about healthy whole grains. She's watching this. What do you want her to do this week?
That's a great question. I think you would learn. It all boils down to what foods put up your blood sugar. And if you can possibly afford a CGM, at the end of 2 weeks, you could know what foods put up your blood sugar and eat nutritionally dense foods that don't put up your blood sugar. And it could be very easy to sort.
Yes.
But healthy whole grains, whatever that means. So brown bread is going to put up your blood sugar, and a jacket potato is going to put up your blood sugar. And
brown rice.
That's right. So if you've got the CGM, you would know. You could experiment, couldn't you? You could have 2 different types of day, and you could try the healthy whole grain day, and then you could try a low carb day and compare for yourself which was most effective and how you felt.
Yes. Yes.
Oh, and finally, I've got a last thing.
Yep.
Loads of free stuff, loads and loads of free stuff. So I helped set up the charity, the Public Health Collaboration. And if you Google Unwin and PHC and the word sugar, you would have free access to the diet sheet we use, frequently asked questions, and the 7 infographics, all translated now into 39 languages and all free of copyright. So you would have access there to a lot of free, it's not advice, it's information that I hope you would find useful. And maybe follow me on Twitter.
And I'll put the
Low Carb GP.
What was that last bit?
Low Carb GP.
Low Carb GP on Twitter, or X as it's now called.
Yes.
And I'll put I'll put those links down in the description so people can look them up as well, and find out more, because there's so much information, as you say, for free, and you just need to start getting hold of it and educating yourself, because you live there in that body. So you need to understand or be empowered with this information that you can make a change. You can change so much and change your outcome, and it's up to you.
Many people have. Many people have come up to me years later and said, "You know what? It's made a massive difference. Thank you."
Yeah, which must feel wonderful. David, it's been such a pleasure talking to you. I know you've got to race off now to go and collect your lambs.
I do.
Cheerio, and thank you very much for your time. I think this is going to be so useful for so many people to hear this from somebody who I think we can safely say is an expert on the topic. So,
I hope so. Emma, thank you so much. And to everybody listening, goodbye.
Bye for now.